There's a bigger group than this last time. I thought they were getting accustomed. So, no, I think you're right. Okay. Oh, was there? So there probably. We got competition out there. Hey. No, you can't leave. We're keeping everybody locked in because we've got such a small group. They were saying there's a conflicting meeting or something. So. Hello and good afternoon, Butterfield Trail Village. Dr. Larry Wright, and this is our monthly talk about all things health and aging. And today we have a particularly strong presentation, I believe, from one of our resident physicians. So this, I'm told, is also being fed into the TV circuit here at Butterfield, so some people are watching it in their apartments. And for those of you who are watching it from home, you can ask questions by calling in on our direct number, which is, let me give you the phone number. If you have questions, the phone number is 479-200-9259. And we'll receive the questions that way. And for those of you who are here, just raise your hand and I'll try to get a microphone to you. So today, I'll just review for you, because although I think most of you know this, we're fortunate to have two resident physicians. So physicians who have attained their MD or DO medical degree and are doing their postgraduate medical training with us in the internal medicine residency at UAMS. And so each month we have two of those resident physicians, doctors, here on campus with me seeing patients in the clinic especially, and at HCC as well. And so this has turned out to be, I think, a very effective way of very thoroughly evaluating people, and I hope giving very good care and service to all of you here at Butterfield Trail. So today, one of those residents, Dr. Punith Thogaripally. Listen, it's even harder to spell. every day or two, I think I've got the pronunciation down, and then I try to spell it. So, Punith Thogaripally. Punith is one of our outstanding first-year residents. He's just about to complete his first year of internal medicine residency training, and he has been a star. He is originally from India, was born in India, immigrated to this country with his family at age 10, and after briefly being in Indiana for a few years, moved to Birmingham, Alabama, where he finished his education and went to medical school at the University of Alabama, Birmingham, which is a very excellent state university medical school. And then we were able to recruit him. I don't know how. I was asking him how were we lucky enough to get him to come all the way from Birmingham here, but he has fit in very well and really at the top of his class. And today we've asked him to give a talk on what is, I hope none of you have it, but everybody's a little bit familiar with the term COPD, chronic obstructive pulmonary disease, the most common type of chronic lung disease, and the most common reason that people have to wear oxygen, and especially continuous oxygen. Well, you weren't scared to sit in the middle? This is so good. Everybody was been pretty much I could introduce Jan too. We worked together, a nurse practitioner, and we worked together for a few years. You're not supposed to let that out? Too late. Too late, Jan. In any case, Punith is one of our outstanding residents. We're so pleased to have him. This is his last week here of 4 weeks, and I think he's enjoyed it. Certainly, residents here have responded very well to him. And so with that, I'll turn it over to him to educate us about COPD.
Thank you for the kind words, Dr. Wright. And I'll speak for the rest of the residents. We certainly enjoyed our time here. So it's been a really good rotation. Okay, we can start the PowerPoint. So my talk will be on COPD, or chronic obstructive pulmonary disease. And my name is Punith Thogaripally, and I'm a first-year resident. So my goals for this talk. Will be first to learn a little bit about COPD and why it's important to know about it. And then we'll get into what are the subtypes of COPD and what are the mechanisms of how you get the COPD disease. And then we'll talk more into the risk factors and the symptoms that patients present with. And then we'll get into the diagnostic tests and then the treatment for COPD. So first, why do we want to know about COPD? So this is the data from the CDC, and they said that there's about 30 million adults in the United States that have COPD. And right now, it's the 4th leading cause of death after heart failure, cancers, and accidents. But the good news is that it seems to be either stabilizing or trending down. And that's the graph you see on the left side. And on the right side, you see a map with the incidence of COPD. So this is how many patients there are with COPD. And unfortunately, it looks like Arkansas is pretty bright. So that correlates with about 10%. So it says it ranges from 8 to 12% of the population has COPD. So we'll get into the subtypes of COPD. So COPD is actually multiple smaller diseases that are grouped together. There are 2 big groups, which are chronic bronchitis and emphysema. But COPD also includes bronchiectasis, cystic fibrosis, and there's also some overlap with asthma as well. And we'll get into how COPD comes on. And before we do that, I have a little bit of anatomy that will help explain COPD. So the image on the left side is kind of a big overview picture. And so you have the nasal cavity where the air enters through the nose, and then it goes down, and on the front of the neck, you have the trachea, and it leads to the lungs. And if you look at the image in the middle, it's just a more detailed image. So you'll see the trachea with the white rings, and these are cartilage rings, and this prevents the trachea from collapsing. And you'll notice these rings continue as the trachea branches out. And the rings continue all the way down until it reaches the bronchioles, which are just smaller airways. And eventually, they'll reach the alveoli, which are the little grape-like clusters that you see in the middle. And this is a very important structure where oxygen exchange happens. And the reasoning for the grape-like structure rather than a big sphere is to increase the surface area so it's more efficient at exchanging oxygen. And COPD affects these alveoli mostly, along with the airway leading up to the alveoli. So you'll see two images with cells. So first we'll talk about the one on the bottom, which is a cartoon structure of the alveoli. And the important thing to note is that it's only one cell thick. So it's a very short distance for the oxygen to travel through. And right outside the alveoli are where the capillaries are, where your blood flows through. So it's easy for oxygen to get over there and CO to come out. And then the top image is the lining of the airways. So this just shows you the first layer, but there's more structures beyond this layer, which we'll talk about in a little bit. So we'll talk about chronic bronchitis first. So this mostly affects the airways right before the alveoli. So the way the body works, especially in the lungs, is we breathe a lot of air in, and it has a lot of antigens, which are just particles that cause your body to react. So as we breathe the air in, your body would constantly react to these particles. So the body fights this by producing mucus that lines the airways. And these airways catch all these particles and secrete them out of the airways. So what happens in chronic bronchitis is, I'll use smoking as an example because I think a lot of people associate COPD with smoking. So when a person smokes, they inhale a lot of antigens, and these particles, most of them will get collected in this mucus and get cleared out. But as we keep smoking, some of these will go through the mucus layer and reach the cells, and that's where your immune system kicks in. And the body is pretty smart. So once it notices that these particles are going through the mucus, it'll act as if the mucus isn't helping, and it'll try to increase the amount of mucus there is. And it does this, if you look at the image in the middle, the black and white image, there are black circles in the middle. These are the mucus secreting glands. So the body says, well, I'm getting pathogens that are coming into me. Let me increase the mucus. So they'll increase the number of mucus glands and increase the size of these glands. And as you can imagine, these glands are in the wall of the airways. So if these are increasing, it increases the thickness of the airways. And as you increase the thickness, the inner diameter, the inner area gets smaller because it's impending with all the mucus glands. That, along with the increased mucus, makes it even smaller. The airways get even smaller, and that's what you see in the image all the way on the right. So the dark pink all the way on the inside is the airway. The yellow on the outside is the mucus layer, which in this case is pretty thick layer of mucus. And then the pink layer outside of that is the tissue which has the glands, mucus glands in there. So the way COPD, the chronic obstructive lung disease, works in this situation is as this airway gets narrow, it's as if we're breathing out of the straw. So if you're trying to blow air out of the straw, it takes you a lot longer to blow the same amount of air out. So it's obstructing your airflow. This is the mechanism for chronic bronchitis. The other thing it does is it prolongs your expiration, how long it takes you to breathe out the air. And this causes air trapping, where your body initiates the next breath without you getting rid of all the air. This causes air trapping and makes your lungs bigger. In COPD, the patients usually have bigger lungs, but they're not moving as much air through them. So the next disease that's part of the COPD is emphysema. And emphysema works kind of similar, but this time the pathogen gets all the way to the alveoli. So the image on the top right, you'll see a cross-section of the alveoli, which is in the middle, and then there's two capillaries on the side. So these capillaries are usually really close to the alveoli, so the air can cross very easily. So what happens in this situation is, if you look at the image on the top left, this shows white blood cells crossing the capillary and making their way to the blue pathogens. And what they're going through is a very thick liquid with a lot of protein in it. So the way the white blood cells get there is by breaking down this protein in this liquid. And they use something called the proteases, which are enzymes. So the body naturally has a balance between proteases, which break down tissue, and antiproteases. But in patients who smoke, their proteases will be really high because their immune system's always activated. So proteases will destroy the lung tissue and the alveoli. There are also other situations, like a genetic condition called alpha-1 antitrypsin deficiency, which does not make enough antiproteases. So there's no checks and balances there. So the end product of this is it'll destroy the alveoli. And if you imagine the alveoli as a balloon with elasticity to them, then this is destroying the elasticity. So the alveoli won't have any elasticity, so they can't push the air out. The other problem with this is, if you look at this image on the left side where you see the airway doesn't have any cartilage in there, so it stays open with tension. And the tension is coming from the alveoli, the balloon. The elasticity from the balloon is keeping the walls open. So if you imagine in emphysema, if the elasticity is gone, there's nothing that's keeping the airways open, so they tend to collapse. That also leads into the obstructive part of it. Here's my cartoon representation of it. So on the left side is a image of the alveoli. And then the bag with the balloons is my representation of a bunch of alveoli at the end of the airway. And as COPD is destroying it, you'll get less balloons. So you'll see the middle image. So if the elasticity is less, it'll turn more into a bag where it doesn't have the elasticity to push the air out. And eventually you'll just get this bag instead of the balloons. And this bag might hold the same amount of air, but it's not able to move that air in and out like the balloons can. So this image shows the relationship between genetics and risk factors and triggers. So this explains why some patients might get COPD at an early age, while others, it might take a long time. So one of the things we already talked about is the alpha-1 antitrypsin deficiency, but there are other genes that affect it, and this affects how much antiproteases that you make. So one of the patients might just smoke 1 pack a day, and they'll get a COPD earlier because they're just not producing enough antitrypsin to keep the proteases in check. Whereas another patient might smoke 3 packs a day, and they won't get it until much later age. So the part of that is exposure, and the other part is genetics. We'll talk about risk factors for COPD, who are at risk for getting COPD. So the most important risk factor is smoking. And then there's other risk factors such as exposure to chemicals, dust. If you cook on an open flame, all the smoke from that, family history, and we talked about genetics. There was a study that was published in New England Journal, and this is one of the graphs from it. And what they did is they looked at all-cause risk for death, and they looked at patients who smoked, and patients who never smoked, and patients who quit. So the top line where you see the 1, that is, so they normalized it to say that patients who smoked get a normalized value of 1. And the second line, all the way on the bottom, at around 0.4, that's patients who have never smoked. So these patients are 3 times less likely to die from any causes, just from not smoking. And the graph in between is, let's say a patient has stopped smoking, and this graph represents how much improvement they'll see from mortality standpoint. And eventually they'll reach, it seems like about 0.6, or they'll be 2 times less likely to die from any cause. So we'll talk about the symptoms and the signs that we see when patients with COPD present. So the most common symptom is shortness of breath, and it's especially worse with exertion. Another symptom is cough, and it's usually chronic cough, and it can or doesn't have to be with sputum production, but you do see sputum production as the disease gets worse. You commonly see wheezing and chest tightness. And the symptoms on the right side these are the physical exam findings that we see. So when you listen to their lungs, you'll hear a wheeze, and it's usually not when inspiration, but during expiration. And they usually have a prolonged expiratory phase, and this is from the analogy where they're trying to breathe out of the straw. It takes a lot longer to get the air out. And in severe disease, their lungs will be really expanded, and they can barely move any additional air because their lungs are already expanded. So you'll hear decreased air movement. And the last sign is they'll use accessory muscles. These are your neck muscles and your chest muscles to try to open the chest up so you can breathe better. Can you go ahead and play the first audio? So this is normal breathing. We'll play it one more time. So the next audio is a patient with COPD, and in this one you'll notice a wheeze when they're you'll hear normal breath sounds with inspiration, and then you'll hear a wheeze at the end of expiration. Can you go ahead and play it? So that wheeze at the end. We'll play it one more time. And this wheeze, we don't always hear this, but with more severe disease, or if they're having an exacerbation of their chronic disease, we usually hear the wheeze. We'll talk about diagnostic tests. So one of the first tests for any kind of lung stuff is getting a chest x-ray. So the image on the left side is normal lung, and the right is a patient with COPD. So one of the first things you notice is that the right lungs are a lot bigger than the left side, the lungs from the left side. And this is from that air trapping that we talked about. So these patients will have a lot bigger lungs, and they have a larger total lung volume, but they can't move as much air through their lungs because their lungs are already expanded. The second thing to note is the diaphragm. So on the left side, you'll see a nice dome shape below the lungs, and the lungs on the right side, you're missing that dome shape. The dome is actually your diaphragm. So the lungs on the right, the diaphragm doesn't have very much area to expand. The next thing you note is the lungs on the right side are a lot darker compared to the ones on the left. And on a chest x-ray, air shows up as black. So the reason for the darker is having this air trapping in your lungs. So these patients will have a lot more air in their lungs and less tissue. Tissue usually shows up as a gray color. So if you look at the lungs on the left side, you'll see this kind of grayish, which is just black, and then they have a good amount of tissue, so you'll see the gray overlapping it. And then the lungs on the right usually just have a lot of air and very little tissue or alveoli. So the next thing is called pulmonary function testing. So the way they do this test is they'll use a device to measure how much air you're breathing in and out. And the way this test works is if you look at the graph, we'll talk about the graph on the right side first. So the graph on the right side, they'll tell you to take a deep breath of air in, and they'll tell you to keep taking the deep breath until the maximum you can hold, and then blow out that air as fast as possible. So this is the graph that you get when you do that. So as you can tell, in the first few seconds, you blow out the most amount of air, and then as time goes on, you'll blow out less, and then it gets flat. After that, you can't blow out anymore. So the important part of this is the black line is the normal, and the blue is patients with COPD. So in these patients, they can't blow out the air as much as a normal patient can. And this is because of two things. One, they're not able to move as much air in and out. And two, they don't have that elasticity from the alveoli. So they're not able to blow out that much air. And this is one of the factors that physicians look at to know the severity of COPD. So in more severe patients, the FEV1, or how much air you're blowing out in 1 second, gets lower and lower. And the graph on the left side, it's slightly a different graph where the x-axis is volume, how much air, and the right side of that x-axis is 0, and more toward the left, that's actually higher numbers. So the bottom part of the graph is where you inspire, and this is looking at how fast the air moves. So in this graph, as you take a deep breath in, you slowly pick up the speed, and then kind of flat lines, and then towards the max, you go back to 0. And then the top part of the graph is expiration. So whenever you try to blow out the air, you blow out really quick, and then the rest of it kind of goes down slowly. So in patients with COPD, they have a kind of similar pattern, but whenever they're trying to blow out, they can't blow out the air as fast as a normal patient. So that's why you see the curve does not go as high as a normal. The other part of it to note is that their graph is shifted to the left, which means that their total lung volume is bigger. And pulmonary function testing is a very important resource in diagnosing patients with COPD. So the next part is classification of COPD, and there's multiple different ways of classification. One of them is called the GOLD classification. So this one uses what the patient is reporting as their symptoms and their acute exacerbations of symptoms and even hospitalizations. So this makes a 4x4 chart. So on the bottom, you'll see the CAT and the MMRC. These are patient questionnaires. The MMRC asks questions such as, when do you get short of breath? Is it with strenuous exercise? Is it with walking really fast, walking uphill? Or is it doing daily activities? And the score of 0 is given to patients who only get short of breath with strenuous activity. And a score of 4 is given to patients who get short of breath with daily activities. And the left side of this 2x2 graph shows hospitalizations or acute exacerbations. So with COPD, you have a decreased lung reserve. So whenever these patients get sick from just viral infections or allergies, they don't have as much lung reserve. So their oxygen saturation will go down and they might need to be hospitalized. So on the left side, you'll see that if they have 0 to 1, that's one group, or if they have more than 1, that's the other group. And you can see the classification as A, B, C, and D, D being the worst. And this is important because medications that we use for COPD are kind of based on this. And for the CAT questionnaire, it looks at cough and it asks patients on a scale of 0 to 5, how severe is your cough? And the same thing with sputum production, chest tightness, daily activity. Are you able to do your daily activities, or do you need assistance? How's your energy? How's your sleep? And based on this, you add the number of, to get your score on your CAT. We'll talk about treatments next. So this slide just includes all the inhaled treatments, and there's a lot of information on the slide. We're not going through all of these. We'll just focus on the main classes. So I just wanted to put this image there just to show you that there's a lot of inhalers that we could use for COPD. So this is the same graph, except now it has an overlay of the treatments that we give for COPD. So the first and most important is smoking cessation. Stopping them to smoke is the most important thing you could do in patients with COPD. The next step is adding a bronchodilator. This will open up the airways so they're able to breathe better and they can blow out some of that air. So some of the classes under the bronchodilators are what's called the SABA, which is short-acting beta agonist. These are medications like albuterol. So this is your rescue inhaler. This is just really short acting and won't last as long, but gives you quick relief. The next one is LABA, which is just a longer acting version of this. So this is the formoterol. The next one is the LAMA, which is long-acting muscarinic agonist. So this is the ipratropium or the tiotropium. This is the Spiriva. And as the disease progresses, they'll add on inhaled steroids. So inhaled steroids like fluticasone. And if the disease progresses even more, they might add oral steroids. Another important aspect of COPD management is oxygen. So when do we decide on giving oxygen to patients? So it's really important to look at their oxygen saturation. If at rest, when they're resting and their oxygen saturation is less than 88, that usually qualifies them for oxygen therapy. The other part of that is if they're walking and are unable to do their daily activities without getting short of breath, or if their oxygen saturation drops with their daily activities, that's another criteria to get them oxygen. Oxygen is one of the only things that's been shown to improve mortality in COPD. And the other important aspect of that is chest physical therapy. We talked a little bit about exacerbations of COPD. So in patients with COPD, we know they don't have as much lung reserves. So any infection or allergen could make their symptoms worse. So if you notice an acutely worsening shortness of breath, increased cough, increased sputum production, or change in your sputum, these are some of the symptoms that we look at to say this patient's having an exacerbation. And the way this works is, if you look at the image on the right, the top circle is their baseline. So this already has a narrowed airway. And whenever they get, let's say, a viral infection, and there's even more inflammation to this area, and more secretions, this gets even more narrower. And that's why they have this exacerbation. So the way we treat this is by giving antibiotics, steroids, bronchodilators, and pulmonary rehab. And as COPD progressively gets worse, the more exacerbations these patients will have. So the more hospitalizations as the severity gets worse. That's all I had. You guys have any questions?
When they pause like this, they're just thinking up harder questions, I'm sure. Well, I thought that was excellent, Dr. Thogaripally. I think, as you can imagine, whether you've known anyone with COPD or not, it's a big challenge in healthcare, because a person who has the diagnosis but is stable can be pretty active, depending on how severe the disease is. But with these exacerbations, they can really collapse pretty quickly. And yes. Okay, it's a good question. You want to tackle that? How does aging affect COPD and affects this kind of scenario? Okay.
So in patients with COPD, as they're getting older, the severity of it usually gets worse. And with exacerbations, it hastens the process even more. So it's important to keep these patients from getting these exacerbations.
Yeah, and a basic effect of aging on the respiratory system generally in all of us, whether we have COPD or not, is we're incrementally losing some of our breathing capacity by the year. For the respiratory system, it's something like 1% of our reserve capacity. Respiratory capacity is lost every year starting at about age 40. And so that's that reserve. We're born with about half of our breathing capacity being reserve capacity, meaning the half of it we never use unless we're in Olympic training or something. But when you it's the reserve capacity that you can call on under stress that allows you to cope with things like an exacerbation or a pneumonia or something like that. But as you lose that capacity, it makes you much more vulnerable, and of course, all the more so if you have COPD. Good question. Good question. Yes, ma'am. So the question is, in the care of people with or without COPD, I suppose, do we ever recommend always? We try, and even when we know they've heard it for years and have chosen not to quit, I think most doctors feel very obligated to suggest that, recommend it pretty strongly, because you know what smoking does to our health is virtually all bad. And I say that recognizing, and y'all have heard it too, hope you didn't experience it, but I've heard it, like in World War II, they were still, and certainly in World War I, doctors were recommending smoking. Some were recommending smoking for nerves, if nothing else. And a lot of people, I've had a lot of people over my career who, World War II veterans who said, I had a doctor recommend I start smoking, and it helped. But then I got addicted to it, and that's the problem. It's such an addiction. It's it is the primary cause for the great, overwhelming majority of COPD. It's the primary cause of it, but it's also about as bad for heart disease and cardiovascular disease as well. So, good question. Yes. Other questions? Sorry. Oh, what does it mean? What does exacerbate? It just means worsening, acute. In this example, it would be acute worsening of your respiratory function. So, or acute aggravation of the COPD symptoms. So, if you got an acute infection with COPD, that would cause an exacerbation or a worsening of your breathing. So that's really what it means. Can you add to that? Sorry, good question. Yes, ma'am. Mm-hmm. So the question is about secondhand smoke, and how much does that, I'll let you tackle
So secondhand smoking affects in a similar way as smoking itself. So you're still inhaling these particles, and it just depends on how much exposure you had to the secondhand smoking, in terms of when you'll get COPD or the severity or if you'll get it. It based on how much exposure to the secondhand smoking you have.
Yeah, you know, if you're sitting in a closed car full of smoke, you can't use the Clinton excuse of "I never inhaled." You're inhaling just as you're breathing there. You can't help but. And so there are a lot of kids grew up with. We for a long time we didn't realize the effect that secondhand smoke has. But you know, I've definitely seen people with emphysema and bronchitis who never smoked themselves, but were exposed to smoke in their house for 20 years, and absolutely, it's a big effect. Good questions. Yes, yes.
So the question was regarding exercising. Does that help in COPD, or does it make things worse? So in COPD, exercise does certainly help. It slows down the progression of the disease, and you definitely do see benefits from it. And how much do you exercise? It depends on individuals. You exercise as much as your body allows, and then try to grow on that.
And I might add aerobic activity, and usually in exercise programs we call that cardio. But it is for someone who has lung disease. In fact, he had slides up here talking about pulmonary rehab, which can be really effective for COPD patients. It's about getting ourselves conditioned aerobically, and when you're conditioned aerobically, your tissues use, your muscles use oxygen more efficiently because of that exercise, and so your activity doesn't put as much strain on the lungs and the heart as if you weren't aerobically conditioned. So that makes a big difference. And I've seen people with really advanced COPD go through pulmonary rehab, and of course they're exercising, doing cardio, you know, walking on a treadmill and doing this kind of thing, riding on a stationary bike, and really doing activity that they couldn't do without oxygen. But while they're doing pulmonary rehab, they're wearing oxygen in order to be able to do this. And after they go through that program for so long, they become so aerobically conditioned that sometimes don't need the oxygen anymore. Now, after an advanced stage, you don't really expect that, to get off the oxygen, but definitely to be able to do more activity. And so it's very helpful thing. Other questions? You're on a roll. This is good. So I wonder, in this select group that's gathered here, I'm so glad to be able to do this face to face again, and I know the audience will grow, because we were often having, before COVID, we like to, if we can remember before COVID, we were often getting 70 people in here for these sessions, and I love that. And I hope we can get back to it. But might just ask the group here, the motivated group that came out today, if there are topics you would like us to address. We're about to start circling back, because we've gone through about, we've done this monthly. We've gone through about 30 topics. So the big ones that I know people are interested in hearing, we've kind of covered. Doesn't mean they couldn't be repeated or updated, but anything in particular you would like to hear about anything to do with health, especially health and aging, is fair. Diabetes. We did that just recently. And they did a good job on it. And in fact, Robin keeps a file of all these. If anybody wants the PowerPoints from previous, probably a little too early to do diabetes this time, but it's simply because we've just done it. But on the other hand, it's such a big one, probably bears repeating at some point. Well, we've done, what about psychological issues? Oh, I think it's a huge and very important part of health, for sure, right? We've done depression. We dig anxiety-related, an anxiety-related topic. I can't remember exactly, but that's a good idea. Memory, yes. Could do it again because I can't remember it, so we might do it again. What did you say, Jan? Yes. We've done blood pressure and hypertension for sure. Blood thinning. We've you know what, we've done atrial fibrillation, in which we talked about blood thinners, but we haven't done blood thinners per se. No, wait. What to expect about exercise generally? Okay. I'll have to hear a little bit more about that, but yeah, that sounds like it has some real potential. Well, thank you for your attention, and please let everybody know we're doing it face-to-face again. It's a lot more fun, more people that are here. Appreciate it all. Listen, this group gets the highest marks for, I think, per capita, more questions per capita than we've ever had. How about that? Yeah, 6 or 7 questions for 12 people. That's pretty good. I'm sorry? Absolutely. Yeah, maybe we could do one on humor. Laughter is the best medicine. I really believe, I don't know how you get through life without a sense of humor. I tell people all the time that I've told my wife, if I ever lose my sense of humor permanently, just shoot me. Life won't be worth living. So, I think she believes me at this point. I don't know whether she has a gun. Well, thanks everybody for coming, and I want to thank you. I want to thank you all for the warm reception we've had. The doctors that we bring out here, and myself, UAMS generally has had here at Butterfield Trail. Everybody's so excited about our being here, and it's such a great teaching environment, setting, and you who have been patients and others who have been patients with us have been so gracious and helpful and understanding and supportive of the residents. I can tell you, and it won't surprise you, you've heard enough stories about medical training and being an intern and this kind of thing. It brings on some stress. And I think how gracious everybody's been here and how kind has made this a very popular rotation in our residency. I can tell you, everybody wants to get back here, and I love that. Now, maybe it's because we don't make them stay in the house overnight like they do in the ICU and things like that, but I think it's just because it's the wonderful people they're meeting. So, and the bistro probably, now that it's open again. Had one resident who said he had had a different soup every day he was out here. Thank you so very much.